Good Saturday morning, everyone. Another rainy Saturday. Welcome aboard. I'm T.O. Souryal, your host for Inside Sports Medicine. Over the next 2 hours, you're going to be entertained, informed, and hopefully learn something new about the world of sports medicine, my world. You're going to have your chance to call in 855-787-1033. Those of you who are early risers, go ahead and queue up 855-787-1033. You're also going to have a chance to text 64636. Start off with the letters ESPN and text me your questions, comments, and what have you. We have lots to get to today. The studio is full. Of course, my recurring guest, which at some point I'm going to have to quit calling him that. Dr. Scott Blumenthal is here. DJ Ringenberg is here. Tyler Sloan is here. Kevin and Daryl are here. Lots is going on. So this is the 528th live episode. 528, 15th season coming up in the fall. We're going to finish our 15th season. Who knows what we're going to do after that? Sports medicine. Lots of sports medicine going on. I want to share a little story with you to follow up on last week's show. So last week was the Tommy John show. And, you know, we spent a long time discussing Tommy John surgery. Had a lot of comments on Facebook as a result of that. I texted Dr. Andrews, who was the surgeon who performed the surgery, apparently. At least that's what I saw in the press release. And he didn't call me back till after the show. So he and I chatted a little bit about Tommy John surgery and what is the expected result. And the cool thing about that conversation was the fact that he actually called me from his boat. And it takes longer to come back than everybody thought. So that in mind, he didn't say anything about Yu Darvish. In fact, at the time, I didn't even know that he was going to be the operating surgeon. I believe that the Rangers pitcher was looking around at 2 or 3 different places, had 2 or 3 different appointments. So I didn't know that Andrews was doing it. But we were talking about generalities. You know, ACL surgery takes 6 to 8 months, give or take. You know, you wait for the graft to heal. And, you know, during the time you're waiting for the graft to heal, you're working on, you know, strength and range of motion, et cetera, et cetera. And how is it different when you're talking about the elbow? We had a great conversation. Much of it was a bit too scientific and in-depth to air on the show because he was using words that I didn't even know. And but the gist of it was that as we do more and more Tommy John procedures, we're learning that it takes longer and longer to come back from. Isn't that interesting? Scott, are you...
I think it's interesting that you called him about Tommy John surgery in relation to this whole Yu Darvish thing without really knowing, because I didn't know till I read it in the paper Monday, the day before, that he was going to Pensacola,
right,
to have it done. It's not surprising. I mean, a lot of athletes go to him for knee. It seems like knee, elbow, and shoulders kind of.
Well, that's pretty much sports medicine.
Yeah, I guess.
Yeah, I don't think they go there for a foot and ankle. They go elsewhere for foot and ankle, and which is going to be the sports medicine 101 topic: 5th metatarsal fractures. While that might sound like a rerun, it's not a rerun because you guys heard me talk about this before. So stay tuned to the top of the 9 o'clock hour. Sports medicine 101, 5th metatarsal fractures. They're in the news this week.
What? I'm gonna ask you a question. Is it
going to be about 5th metatarsal fractures?
No, I thought you were going to talk about that later.
Oh, good.
I was talking about this Yu Darvish thing. As a team physician, how would a team physician feel when an athlete you've been taking care of and you've diagnosed correctly and says, "Oh, I'm going to get a second opinion. Oh, and by the way, I'm going to have the second opinion doctor do it, not the team doctor of the Texas Rangers." I mean, who's a really good doctor.
Yeah.
We both know him.
It doesn't feel good, but I think that's baseball. That's been my impression of sports medicine in baseball, and it's been that way for years. The the top players in baseball, again, my opinion, my impression over the years, rarely stay at home for their procedures. They often go to a third place.
What about off season? Because you see football players in the off season sometimes going to Andrews for their knees. Knees kind of, if you're a football team doctor, you're really good at doing knees.
Yeah. Again, now in football, most of the guys stay with their team because there is a time urgency. If it's during the season and the guy needs a clean out, their team doc is going to do that, and it's going to stay in Pittsburgh, Dallas, New York, wherever. Rarely do those guys travel around. If it's a season-ending injury, for example, Adrian Peterson and his ACL a few years ago, he went to Andrews.
Right.
So in football, they tend to stay home. In baseball, they always tend, well, I shouldn't say always, they tend to fly away. In basketball, it's kind of a mix. As a general rule, over my time with the Mavs, the guys have stayed here. And in fact, it actually works sometimes the other way, where I see players from other teams. So in basketball, it's kind of a mixed bag. Sometimes they stay, sometimes they go. But, you raise a good behind-the-scenes look. Question as to what it feels like if you're the team doc. I don't think any of us like it, but it's the nature of the business. There are some procedures, though, that I wouldn't want to do. I will send the guy out, and I can't think of the last time something like that might have happened.
But it sounds good.
But there, yeah, I mean, if one of our guys, for example, you saw Tim Duncan not long ago get his elbow caught and had a minor sprain on his elbow. It was on a pick. His arm was extended. Somebody ran into it, and I don't know the details, but if that, for example, evolved into an ulnar collateral ligament tear and he needed Tommy John surgery, I wouldn't do it. I don't do enough of those to stay proficient. So I probably would send that out.
And that's a measure of wisdom, because it's the same thing. There are certain spine procedures I do all the time, and then certain ones that I may not do that frequently. And I'll send a patient even to a colleague in town if they need a specific type of surgery that they might do 10 a year and I might do 1 a year.
And that's the interesting thing about the business of medicine. Now, this was not a planned business of medicine segment, but it does dovetail nicely into what we're talking about. With reimbursement declining, what I have noticed in the sports medicine and orthopedic world is that because the surgeons are under tremendous pressure to pay the bills, they're doing procedures that they're not proficient at.
And some of it's ego too. When you're younger, you think you can do anything in your specialty. So, whether it's sports medicine or spinal surgery. Oh yeah, I finished my fellowship a couple years ago and we did Tommy John surgery all the time. Well, I haven't done one since I've been in practice, so I can do it. I did a lot in my fellowship.
Some of it is ego, and I'm with you on that, but I think a lot of it is, unfortunately, the business of medicine.
Yeah.
All right, let's go to Chad. We promised phone calls. Chad, good morning. You're on Inside Sports Medicine.
How you doing, Dr. Souryal?
I'm good. What's up? What you got?
I've got a strained abdominal muscle from powerlifting. About 2 years ago.
Did you call before?
No. This
Okay.
is actually, I've been wanting to call a long time, but this is the first time I've been able to call.
All right. Well, I'm glad you did. But yeah, I had a similar call a couple of weeks ago. So go ahead. Keep going.
About 2 years ago, in the gym, was doing leg press, felt a slight pinch in my abdominals the next day, really bad pain. Went to the doctor. They told me it was just a strained abdominal muscle. Stayed out of the gym for about 2 months. Went back, did light weight, and about every 3 months, every time I get to about a heavier weight, it seems to come back. And I've seen about 3 different doctors, and they all tell me it's not torn, it doesn't need surgery, it's just a strain. But if it keeps coming back, I'm wondering, is there something else to it, or is there anything else I could do, or could it be something more than a strain?
The answer is yes. I mean, one of the items on differential diagnosis, and we talked about that last week, what a differential diagnosis is. When we teach the new doctors, to me, the diagnosis is key. And I had a few patients in the office yesterday as second opinions, and one of them has actually had multiple surgical procedures. And I asked his mom, I said, what were all these surgeries for? Because they seem to be unrelated, so there was an ankle problem. I'm going somewhere with this, Chad. I'm not wasting your time. Sorry.
Okay.
So he had a surgery on his Achilles. He had a surgery on the peroneal tendons. He had a scope on the front. I said, what were all these surgeries for? And she said, well, I don't know. We don't really have a reason for his ankle pain. Well, I said, unless you have a diagnosis, then there's absolutely no way to tailor a treatment plan. And so with that young man, there was not a working diagnosis. I think someone was just shotgunning and trying to fix this and fix that. But that may not have been what was the problem. So we teach interns and residents to, when you hear a set of symptoms, make a list in your mind of what this could be. Yeah, abdominal strain absolutely is probably number one on the list in a person who's heavy with working out. But you got to consider hernia, and when you consider hernia, there's like 5 or 6 different kinds of hernias. It's not just the garden variety inguinal hernia. There's other types that it could be. There's even something called a sports hernia, which is not even a hernia at all. And it sounds like you kind of need to pin down a diagnosis. When your symptoms come back, is it always in the same spot?
Always.
There you go. Okay, that helps me. Is it, and again, we're on radio, so we'll have to be cautious with our word choices. Is it up around the belly button or lower?
It's up around the belly button to the left, like right inside my left hip bone.
There's actually a really bizarre little hernia in that spot. There really is. I cannot remember the name of it for the life of me. Scott, do you?
Femoral?
No, it's way up by the iliac crest. Look, here's what I'm going to tell you. I like Ralph Parker. We send Dr. Parker all of our sports hernias, and yours does not sound like a sports hernia, but I think that you probably ought to see somebody and get a diagnosis, because recurrent abdominal strains are not common, and I've been doing sports medicine for 25 years. Yes, you'll see a strain. You perhaps might see a recurrence early on simply because they didn't give it enough time to heal. But recurrences every few years is pretty unusual. Right.
And every time it happens, I'm out of the gym for probably 2 to 3 months at a time, just to let it heal, icing it, and.
You know what? I hate to say his name again on the air, but go see Dr. Parker and figure it out.
Okay.
Good luck. Let me know.
Doctor.
Let me know.
Sir, thank you.
We don't get many abdominal questions.
We don't, but there is. I'm sure there are a lot of doctors that are listening. So if you're one of the docs who are listening, and you can remind me what this is, but it's a little triangle up where the rectus and the obliques. I can't remember the name of it. It's not orthopedic.
Do you see a lot of those kind of sports abdominal injuries?
I see sports hernias quite a bit, because I used to take care of FC Dallas, and soccer players get sports hernias, and you see it a little bit in basketball. So I see quite a few, hey, doc, do you think this is a sports hernia kind of patients?
But it's not really a hernia.
It's not a hernia. It's a misnomer. It's a
muscle tear.
It's a tendon insertion tear. It's a form of tendonitis is the way I describe it to people.
So it's kind of a misnomer, sports hernia.
Did you intentionally mean to go there?
No.
Because I've got phone calls.
Oh, I don't have a board. I can't see phone calls. I can't see text.
Whoa, we're going to have to fix that.
So I have no idea where you're going.
Oh, no. My bad.
I'm kind of sitting out here.
We're going to have to fix that.
In the dark.
Oh, my production crew. Golly. So apparently they can hear us loud and clear in Oklahoma. Oh, wait. So do I believe this? 5205 texting from Alaska?
There you go. It's kind of early there, isn't it? working the night shift.
I've always wanted to go to Alaska. It's on my bucket list. All right, let's go to the phones. I promised. Robert, good morning. How are you?
Good morning. I'm good.
Good.
I have a rotator cuff problem. I went to the doc. I play a lot of golf. He said, after reviewing the x-rays, he said, you have it's not torn rotator cuff. You have bone spurs, and you have some bursitis. And I lift weights. He said, here's the shot. I'll give you this shot. Use these light weights, light bands, and don't do any heavy lifting, and this ought to take care of it for you.
Did it?
Well, I just started with the bands. He said, wait 10 days after the shot, the cortisone shot, before you start doing the bands. So I'm just starting on the bands. But the question is, I think it's going to be a temporary. If it works at all, I think it'll be a temporary. The pain's a little bit better, but is this a permanent or a temp?
You know, that's a great question. That's an absolutely great question, and I get that quite a bit in the office. So, we see shoulder problems often in sports medicine, and it's a spectrum. You know, it's a spectrum. You fall on the ice, you land on your shoulder, you tear your rotator cuff, you can't pick up your arm. That's an easy diagnosis to make. Hey, doc, I could pick up my arm yesterday. Today, after the fall, I can't pick up my arm. That is a clear cut. On the other end of the spectrum is the tendonitis and bursitis picture, which may be you. It may be you. Now, I like what you said because your doctor got an x-ray and he saw bone spurs. That's all you can see on an x-ray are bones. You cannot diagnose a rotator cuff on the x-ray. You have to have a soft tissue test like an MRI to be able to detect that. So you went to the doctor, he examined you, he took an x-ray, he saw some bone spurs. You know, he made the assumption that this is probably a bursitis, which is on one end of the spectrum of rotator cuff problems, and he appropriately injected it and is going to start you on. Everything that you've described to me is exactly what I would do in my office. Now, to answer your question, is it temporary or is it permanent? If it's the beginning and the first symptoms are a bursitis or a tendonitis of the rotator cuff, then this may be a permanent fix. You know, you put a cortisone shot in there, the tissue shrinks down, you do some strengthening, you're done. But if the symptoms come back, or if the cortisone shot does not work at all, or if it works but for a week or two and then it goes away, well, then you've got to consider that there may be more to it than just the bursitis. We have to consider that you may be farther along on that rotator cuff spectrum than the beginning stages. Now, granted, it's not a complete tear. You didn't fall. You can lift up your arm. But I can't tell from an exam whether you have irritation of the cuff, a partial tear of the cuff, or even a small tear of the cuff. Can't tell. Can't tell on the exam because they all look the same. But you can on an MRI. So if you're one of those people where the shot does not work or it only works for a week or two, then you're obligated to go the next step for an MRI. Does that make sense?
Yes, it does.
I love the question.
Oh, hang on.
Because we see this all the time in spine. So you have bone spurs, which is a sign of wear and tear type of arthritis, for lack of a better word. And I guess I get asked this question all the time. Well, if I do therapy or cortisone shots, is this just temporary? Well, the reality is, aside from a full tear of a rotator cuff, most of these types of things are a degenerative condition. They're wear and tear. So we can't reverse aging. So a lot of things we do, yes, are temporary, and you either live with it, you modify what you do, and frankly, and Tarek can correct me if I'm wrong, rotator cuff tears impact mainly overhead type stuff, sports. Most golfers can play with rotator cuff pathology because it's not an overhead sport.
Yeah, the golf swing, really the rotator cuff is somewhat protected in the golf swing.
Yeah, you're more likely to be impacted on your weight workout than you are on your golf.
Right. So if you've done a lot of weightlifting, especially overhead stuff, if you've done a lot of push-ups, then my guess is that's the culprit, and that's probably caused some AC joint arthritis, which is what caused the bone spurs, and the bone spurs are impinging on the rotator cuff, causing either a tendonitis or a bursitis. Wow, that's a mouthful what I just said.
And you got it all out. That was good.
I did. Robert, you're on the right track. Keep us posted. And good luck. We got to run.
Thank you very much. Bye.
Right. So this segment we like to call Sports Medicine 101. If you know the name of that theme, go ahead and text me. 64636.
I think I do. I won't say it, but I think I do.
You have to be a certain age to know that. And the reason I picked it is because it is simple and basic. So Sports Medicine 101, we're going to talk about fifth metatarsal fractures. It's been in the news lately. And this is one of those injuries. The fifth metatarsal is the bone in the foot. So metacarpals are in your hand. Metatarsals are in your foot. You clap with your carpals, you tap with your tarsals, and that's how you remember it.
Was that from med school?
Yeah.
I don't remember. That's kind of like those mnemonics that we used to learn.
You didn't know that?
I didn't know the tap and the clap.
Okay. Now 25,000 people are going to know the clap with the carpals and tap with the tarsals.
We'll see how many of them remember it tomorrow, though, or in an hour.
You can't forget that. That's one of the, isn't that funny about mnemonics that you can't forget it. It's forever in your brain.
I'm sure we did have that in med school, but that wasn't one of those hard things for me to remember. Unlike the cranial nerves, those were hard to remember.
The 2 through 12? Yeah, I can't even remember what that. I don't even remember the mnemonic. Better yet, what the cranial nerves are.
I do, but it's not for prime time.
You're distracting me.
I thought we were talking about medicine.
No, we're talking about fifth metatarsal fractures.
Oh. Well, they just on ESPN flashing across, we're just talking about the player with the player. The player.
The player, right.
The player.
Okay, so over the years, and I've been doing this for 28 years now, I have learned to respect fifth metatarsal fractures because they don't all bounce back the way that you think that they would. Now, the vast majority do. I was sitting here and talking to Daryl, who has been kind enough to work with us for the last year, helping make this a better show. And turns out when he was playing basketball, he had a metatarsal fracture, and it took a while to get diagnosed. But when you do get an X-ray, and usually it's pain at the base on the outside of the foot. The metatarsal is the bone that is it's the long bone of the foot, and the fifth is the one going to the little toe. So it is on the outside part of the foot. It's halfway between the ankle and the little toe. And sometimes it starts off with some discomfort, and people think that they're sore. And other times you land from a rebound and you've got an acute pain right there. Those are easy to diagnose. You take an X-ray, you see the fracture line, there you have it. But it normally looks relatively innocuous, and you think, well, this thing ought to heal. Well, the majority do. So one of the options is to put an athlete in a boot for a while, and that will heal. Sometimes, however, it doesn't heal, or it doesn't heal very quickly, and you end up doing surgery to put a screw in it to try to compress the bone. And the problem with athletes or the problem with a fifth metatarsal fracture is you can't tell on day one which are going to heal just fine and which are going to require a screw. So for athletes, usually we just put in a screw. It's a straightforward procedure. It's not very lengthy. It's a very small incision. You put in a screw to compress the fracture and hope that it heals. Well, guess what? Not all of those heal either. And this is what has happened in my 28 years of experience that has taught me to respect this injury. I'm not talking about the 95% that are going to heal whether you put a paper clip in there or whether you put them in an ACE wrap. I'm talking about the percentage that don't heal even if you put a screw in there. I've had dozens of these in my career, many of them on professional athletes, and this seems to be rampant in basketball. Lots of fifth metatarsal fractures in basketball at all levels. And, it's, again, you try to prepare the player, you try to prepare the management, you try to prepare the agent that, look, I'm throwing a kitchen sink at you. I'm putting a screw in there. I'm putting bone graft in there. I'm putting BMP in there. I'm putting everything I can possibly put in there to get this thing to heal. And there is still some that don't. And it's a real challenge if you're one of those where it does not heal fully or does not heal properly. And turn the music off. There you go. So that was Radio 101. Radio 101. I'm not a radio guy. So there's some that just don't heal, and it's problematic. And then so what do? You take the screw out, you try to put in a bigger one, you put in some bone graft, you wait some more time. It's one of those injuries where I have tremendous respect for it, and we don't have a real good answer. You can put up an x-ray of someone who has a fifth metatarsal fracture, and I cannot tell you how that's going to end up. Frustrating on every level, but that's the way it is, and the best you can do is prepare people. If you say, this will heal just fine, and then it doesn't, well, then you're in trouble.
I wonder if there's a way to use technology to be able to predict problematic fifth metatarsal fractures, things like MRI spectroscopy or some of this new stuff out.
Funny you should say that, because the research committee for the NBA Team Physicians Association is looking at that exact topic. We're trying to figure out if there is a way to predict who's going to be in the 95% kettle and who's going to be in the 5% kettle. So so you're absolutely right. I don't know if technology is the answer, but research is the answer.
Yeah, I mean, with all of your busy practices, not just pro athletes, but to take all your fifth metatarsal fractures and whatever you think might be a predictor, whether it's 3T MRI or I don't know, it would be good to start prospectively looking at it and then characterizing what their features were that made them fall into the groups.
We're doing it.
That's awesome.
You're on top of things. All right, so that was Sports Medicine 101. Someone did know it was not what? It was not Cinderella. So wait. So let me. I want to be as respectful as possible to 10054 from Oklahoma. He said, "You asked this question a few months ago. It was Cinderella." No, it wasn't Cinderella, and I did ask this about 4 or 5 years ago, and it's the Leave It to Beaver theme. Somebody actually already got it right. 0178. No contest. Just curious. All right, so taking your phone calls coming up, 855-787-1033. All right, Carolyn, how are you?
I'm doing great. How are you?
We're doing well, thank you. What you got?
Well, I have a 15-year-old granddaughter that plays soccer, has played since she was probably 5 years old.
Okay, so just so you know, in my brain, I'm making a list of what happens to 15-year-old soccer player girls.
Oh, no.
Keep going. Yep.
Okay. She has a pulled hamstring for the first time in her soccer career. She has been diagnosed with the pulled hamstring. He's saying 3 weeks rest. If that doesn't work, 6 weeks rest. She's on a rec team and the high school team they're through. My question is this, and I know this is probably not answerable, but can this heal? I mean, is this going to be something that's going to nag her from now on, as long as she's in high school playing?
Great question. That's you know what, guys? I'm glad you made me take this call. That's a great question.
And this is a grandmother now, so.
Well, I appreciate the fact that you care, and I appreciate the fact that you're calling in. That's really cool. Okay, so I have a couple of questions before I can give you my answer. Is it pulled way up high, close to the butt?
Yes, it's up in the thigh part. But she says she hurt so bad 2 weeks ago when she played in a tournament.
Was it acute?
In her groin,
was it acute? Was there something that popped?
No. It's just I guess it was just a pull. It's a mild pull, he says.
Yeah. So here's my thought. And this is 28 years of experience. Typically in someone that age, the growth plate is still open. So this is more likely a growth plate irritation. We call it ischial apophysitis rather than an actual hamstring pull. And if I'm right, if that is what she has, those heal beautifully. Those heal just fine. Once the growth plate stops growing and the bone matures, you'll never have another problem with it. But just next time she goes to the doctor, ask him or her if it's possible that that's what this is. I rarely see proximal hamstring injuries in adolescents. Rarely. Yeah. So it's either a growth plate irritation, a growth plate avulsion, or the more classic hamstring in the middle of the calf or in the middle of the thigh, and they say, ouch, I just hurt it.
Yeah.
All right, thanks. Got to go.
All right, thanks, doctor.
Great.
Bye-bye.
What a great call to end up on. Okay, so people are suggesting Oklahoma as the fourth fight song in our bracket, or Texas A&M.
Well, we'll have to put him in the Elite Eight.
We'll have to figure that out. But this guy from Oklahoma says, I couldn't even identify the Texas fight song. Wow. It's the Eyes of Texas, isn't it?
Yeah.
Yeah. Okay, so I want to plug this before we leave. I want to plug two things. Number one, we have a YouTube channel. And much of what's on YouTube, you guys might find very entertaining because it's the video from the behind the scenes when we're on break. So go to our YouTube channel. It's Inside Sports Medicine Radio Show. And just browse it around. You'll see some of the on-show stuff. You'll see some of the behind-the-scenes stuff. And hopefully you're going to find it entertaining. We also have a few nuggets and podcasts on our website, InsideSportsMedicine.com. Don't forget to go there as well. We've had a sponsor now for the past 6 months that I'm terribly, terribly excited about. And it's Fiat Alfa Romeo of McKinney. And really good folks in McKinney. And one of the cool things, the reason I'm talking about this right now, is because they have the new Alfa Romeo 4C, and what an absolutely cool car. It is worth going up to McKinney just to look at it. All right, on behalf of all of us here, Scott Blumenthal, DJ Ringenberg, Tyler Sloan, myself, everybody on Inside Sports Medicine and ESPN 103.3. Until next week,
tell your friends.